How to do a proper sign out or handoff. We do 3 ways of signing out. We do verbal or peer-to-peer, written through Epic Handoff, and bedside for sick patients. All should have the same information relayed. What should our sign out include? We follow a mnemonic called DASH, which includes demographics, admitting diagnosis, active status, current status of the patient, have to do, and plan. Never sign out the following. Blood draws that are due. ABGs should be followed by the signing off team prior to sign out and act on it, which includes intubation, BiPAP changes versus MICU consult. Never sign out IV access issue. Plan was supposed to be done during your shift, includes consults and attending notes. Here are some examples on how we sign out patients.
Right. So this is a 45-year-old male. He has a past medical history of hypertension and cocaine use disorder. He came in with chest pain for the past 2 days. That's actually worsening in intensity. We did an initial EKG that is unchanged from his baseline, which was normal sinus rhythm without STT wave changes. And his initial troponin that we did is negative. This was done at 3:30 in the afternoon. The plan for now would be to keep monitoring him. We just dropped down a repeat troponin that is due at 7:30, so you would need to follow that. It's in process.
Okay.
The EKG will be done is done as well, so you can follow that up. It does not show any changes, but you can check that as well. The plan for him would be to monitor his troponin every 4 hours. Obviously, we follow the one now. If it's going up without any EKG changes, then likely it's an NSTEMI. We monitor how he's doing, his vital signs and his general, basically vital signs, and then follow the troponin 4 hours later. Now, if it's going up, it's a clear-cut NSTEMI, we transfer to Bellevue. But if there is any doubt in decision making, we can also involve our overnight attending to make any further decisions in regard to his medical management.
Okay, but how is the patient doing now? Is there any active chest pain?
Right. So currently he is on room air. He's saturating 97%. His blood pressure is 130/90, and his heart rate is 75. Currently, he is not complaining of any active chest pain. His vitals are stable.
Okay. So I'll just the loop. So the current troponin is in process.
Yes.
The first one is negative. If it's trending up, I'll correlate it with the symptoms and the EKG. If I have any questions, I can call the attending on call, right? So, but most probably, like,
if it keeps trending up,
I transfer to Bellevue.
Exactly.
Okay, got it. Thank you.
So this is an 88-year-old female who was admitted a week back. She has a past medical history of dementia. She was admitted for a fall. She was seen by the physical therapist. They suggested subacute rehab. So the plan is for placement of subacute rehab. She's just pending insurance authorization. For you, over the night, nothing to do.
Okay. So just regular monitoring protocol.
Yeah, that's it.
Okay.
So this is a 60-year-old female who has a past medical history of uncontrolled diabetes and hypertension. She's come in with abdominal pain and polydipsia, polyuria. She was diagnosed to have diabetic ketoacidosis. She has 2 lines. She was given 4 liters in the ED. She started on an insulin infusion at 3 units per hour. Her last finger stick at 7 p.m. showed 355 of blood glucose. Her last labs that were at 3 p.m. Showed an anion gap of 18, a bicarb of 13, and a potassium of 5.3. Her repeat labs would be at 7 p.m. They are in process, and you can follow them. She's also on maintenance fluids at 150 cc's per hour. That's pretty much it. The VBG that we did at 3 p.m. showed a pH of 7.28.
Okay, so I'm gonna so basically the labs, BMP, electrolytes, ABG will be every 4 hours.
Yes.
So the last one will be in process. I wanna know, Adi, what's the running fluid now?
Right. The running fluid now is NS. It's at 150 cc's per hour.
Okay.
Given that her finger stick is on the downtrend, if the repeat finger stick at 9 p.m. shows that it's going below 250, the plan would be to start her on D5 as well,
Okay.
since it's going down.
Okay. And then the patient is feeding, right? So there's no nausea, no vomiting.
No
and we
nausea,
have
no
2
vomiting.
lines.
And we have 2 lines.
Okay. And then what will I do with the anion gap trend?
Right.
Like for example, it goes up or goes down.
Right. So if it's going down, which is what we want, and if the labs at 7 p.m. that results show that the anion gap is closed, we repeat one 4 hours from now, which is 11 p.m. In case the gap closes at that time, we bridge her to subcutaneous insulin.
Okay.
If the gap still is uptrending, then we go up, repeat, we go up on the insulin infusion and the D5 in case it's the finger sticks are dropping, and follow the VBG. In case the pH is going down, the next step would be an ICU consult, depending on how low the pH is. But if the gap is closing twice, then we can bridge her to subcutaneous insulin.
Okay. How about the potassium? Are we replacing it now?
Right.
Or
So since the last potassium was 5.3, we haven't actively acted on it.
Okay.
And given the fact that her blood sugars are dropping, we might have to go down on the insulin drip, but we wait for the labs at 7 p.m. In case it's going below 5, I think it would be good to replete it.
Okay. And when will I stop the insulin at what potassium?
Right. So if the potassium drops below 3.5, I think we should stop the insulin infusion.
Okay.
And check, repeat the potassium as soon as possible while repleting it.
Okay. Thank you.
No problem. Right, so this is a 60-year-old female. She has a past medical history of hypertension and diabetes and COPD. She was admitted for shortness of breath for the past 3 days with sputum production, with cough. She also complains of decreased exercise tolerance. She was diagnosed to have COPD exacerbation. Her last intubation was more than a year and a half back. She has been intubated 4 times. She also has 1 exacerbation that was previously a couple of months ago. She did not require an ICU stay at that time. In the ED, she received a dose of steroids. She got 3 DO-nebs, and since she was not improving, we did an ABG. The ABG showed a pH of 7.31, a PCO2 of 80, and a PaO2 of 89%. Given these, she was placed on a BiPAP with the settings of an IPAP of 14, an EPAP of 5, an FiO2 of 28%, and a respiratory rate of 16. That's pretty much what we did for her in the ED. Any questions from your side?
So what time did we last do our ABG?
Right, so the first ABG was at 6:30 p.m.,
Okay.
which is when we placed her on the BiPAP.
Okay.
We did a repeat ABG at 7:30 p.m., which shows a pH on the same settings, which shows a pH of 7.32, a PCO2 of 75%, and a PaO2 of 92%.
Okay. So Adi, how was the patient when we first received?
So initially when we saw her, before she was placed on the BiPAP, she was tachycardic to the early hundreds. She was tachypneic to 32, 33. Her blood pressure was 149/80, and she was afebrile.
Okay, but she's awake, right?
Right.
Okay.
Right.
Okay.
So while she was on the BiPAP, she was tolerating the BiPAP pretty well. She has a good mental status.
Okay.
And the plan for now would be to repeat her ABG 1 hour from now, which is 1 hour from the last one, which is at 8:30 p.m.
Okay.
We would need to write her a BiPAP assessment note every 1 hour.
Okay.
And the plan would be to see if her PCO2 is on the downtrend, and if she's doing well, possibly take her off the BiPAP overnight.
Okay. So would you mind if we see the patient now at bedside?
Definitely. We can do a bedside sound as well, just to assess how she's doing.
Okay, great. Thank you.
Okay.